So I guess we'll start ahead. Dr. Murphy, you'll have an extra 2 minutes to speak. As Dr. Murphy is the Senior
Right.
Associate Dean for Clinical and Translational Research, as well as he's heading up the new Community Health Equity Research Institute, and I believe he's going to speak about both of those. So Dr. Murphy, I'll let you go ahead.
Thank you, Karen. And I'm going to share my screen, which I'm doing, and now I got to do that. Okay. So yeah, thanks for the opportunity. I see and welcome everyone. I see lots of names, lots of familiar names, and new names, and welcome new folks to UB. And so I am going to talk about both things, as Karen said, the Clinical and Translational Science Institute and the Community Health Equity Research Institute, largely to talk about the resources that are available that we would encourage you to take.
Dr. Murphy, your audio cut out.
Huh? Do you hear me
Oh,
now?
now I hear you. Yes, now you're
When
okay.
stop. How much did you miss?
Just a couple seconds.
All right, good. All right. The Clinical and Translational Science Institute, I think of it as three things. We have way too many acronyms, but it's the CTSI, and it includes the building and the downtown campus, Clinical Translational Research Center. It includes an NIH award, the Clinical and Translational Science Award, or grant from the NIH, which also comes with a lot of institutional support, UB support, and the Buffalo Translational Consortium, which is 20 institutions or thereabouts. And I'm not going to go through each one, but I can show you that the blue is the health sciences schools of UB across the top. We have our clinical partners. We have research institutes that bring special expertise, and we have very important community partners as part of our consortium to advance clinical and translational research at UB and among partners, so really in Western New York. And our vision is to advance and accelerate research to improve the health of our community and reduce health disparities in our community and the nation. The idea being if we can develop tools here that work in Buffalo, they're going to work lots of places because many cities have health disparities, sadly, like Buffalo does. So our work in the CTSI is really strongly connected to our community. So here is the website, and there's the link, and I will share my slides, and I would encourage you to explore the website, which actually we just updated and made it much easier to navigate. And I'll show you where these two, the community person can go here and click, and then all the resources that would be likely most of interest and pertinent to the community can get it from there. And then similar researchers, the ones that are used a lot. But take a look at this as our homepage. If you click on cores, what you will get is this. So we have 10 cores that provide resources to all UB faculty. Everyone here has access to these resources essentially at no cost. Imaging, there's some cost involved, but our most popular one is biostatistics, epidemiology, and research design, BIRD. Probably 60 or 70 consults a year. This will help you with your design your clinical studies, your translational research studies, help analyze your data and so forth. And the one thing I would suggest, the biggest mistake we all make is we engage the research design and the biostats people too late. You should do that at the planning stage of your project, and they'll help you write your grants, basically, with the idea that you'll have a biostatistician with effort on your grant, which most study sections look for anyway. We have an imaging center with MRIs, both for humans, large animals, and small animals. Clinical research facilitation is help with your IRB, writing your proposals. Sanjay was just talking about that, and the clinical research facilitation. Those are two CTSI people who will do pre-reviews on your IRB protocols and help you fix them up. So the idea being they'll fly through the IRB. Community engagement to connect you with community organizations, informatics to help with your data and so forth. The Institute for Healthcare Informatics is very important in that that's where you have access to electronic health record data of almost the entire community. So it's the EHR data from the UBMD practice plan. That's the largest practice in the area, and it's generally faculty from the School of Medicine practices, and then also Kaleida. So you can access it from your own computer in de-identified form. And then, for example, if you're looking to recruit to clinical trials, then you can go to the IRB and get permission to actually contact people. We have the Mentored Career Development Program. That's an early stage faculty, a KL2 award, very valuable, and there'll be calls for applications for those. The next one will be out in 2025. Recruitment will help you with your recruitment to clinical trials. If we look at the pipeline for translational pipeline, the biggest obstacle in that 17-year pipeline is recruitment to clinical trials. We'll help you with that. We have $600,000 a year available in pilot studies, and there'll be a call out each year that generally comes out in the summertime, about May, June. And then we have workforce development, lots of workshops and seminars and so forth that you'll get emails about and so forth. So I would encourage you, when you explore the resources and when you're looking for help with your clinical and translational research, go to our website. All right. Next. So then if you click these, explore resources, explore opportunities, you get here. So this is for researchers, and I'll show you a couple of these things. And this is for, I'm sorry, researchers here, community on the left. I'm just going to show you I told you how important recruitment is and how 75% of clinical trials fail because they don't hit their recruitment goals. That's the biggest bottleneck that we have as clinical researchers. So we have a bunch of resources in this toolkit and study listings, participant databases. In fact, here they are with more details, and you have access to all of these. Each one of these is a link to a resource. And I'm going to show you two of them, I think, just as examples, but each of these is a huge resource for you in terms of not just recruitment, but creating your flyers and that sort of thing. How to use plain language in these things. Health literacy is a huge social determinant of health. We all have to be mindful of. So this is, if you want to know all clinical trials at UB, this is it, participate in research. It took a lot of effort by a lot of people so that we have one resource so you can tell people who you see, as I get asked all the time, is there any place that I can go to find where all the clinical trials are at UB? And here it is. You can see what's going on. You can search by these different groups. You can scroll through all of them. You can search keywords and so forth. Here's a concussion study as first. There's a couple hundred on here that you can access, and we have plain language descriptions of them, and then you click and you get the more details that you want. Buffalo Research Registry is a very valuable tool for recruitment to clinical trials. And what it is a database. It's got about 7,000 local residents that have signed consents and agreed to be contacted about research. And they've given basic information about themselves, underlying illnesses, demographics, age, and so forth. And so you can, when you're looking to recruit people into your clinical trials or your clinical studies or your focus groups and so forth, this is a great resource for you to use. And something special about it is, so in our CTSI, I told you about how it's important for us to connect with our community. If you look at the city of Buffalo, excuse me, the city of Buffalo is 50% underrepresented minority. So, and we are strongly encouraging our investigators to engage people who look like our community and engage people who've otherwise traditionally been excluded from clinical trials. And so we have in this database 51% from low-income zip codes and about half from underrepresented racial and ethnic populations. What this one has been particularly useful for people is for healthy controls, or controls that are not part of your study. For example, we have a great multiple sclerosis group here, and they pretty much follow everyone in the area who have MS. So they're often doing studies where they can easily recruit the MS people that they have, but then they want to recruit an age and population matched healthy controls. This has been a very valuable resource. So keep this in mind as well for your recruitment. And the easiest thing to do, if you go to that recruitment toolkit, is ask for a consult, and our experts will tell you you would benefit from this resource, and this resource, and they'll help you develop a recruitment plan for your grant. And that's the best time to ask for a consult, but then also help you recruit for a study that is beginning or ongoing. Let me talk to you. This is one of the reasons why we have focused in the CTSI on health disparities. So this is Erie County, which Buffalo, for those of you new to Buffalo, Buffalo has a population of about 280,000. The city of Buffalo, Erie County has a population of about 950,000, so about a million. And Buffalo is the biggest city in Erie County. And you can look at the health outcomes and some of these data, hospitalization rates and so forth, for the different groups, ethnic groups. If we look at the city of Buffalo, it's 37% African American and it's about 14% Latinx. Erie County is about 13 or 14% Black and about 4 or 5% Latinx. And you can see the incredible health disparities that exist in Erie County. Look at stroke mortality in particularly in Black and Hispanic populations. Look at the asthma hospitalization rate in white people and Black people in Buffalo. That's because a lot of that is because the asthma is just not managed. It's managed in emergency rooms, unfortunately. And then the very disturbing low birth weight and infant mortality that exists, race-based inequities, and this parallels, unfortunately, national numbers as well. But we need to do something to correct these numbers. So, so the Community Health Equity Research Institute resulted in large measure from a partnership between the CTSI and other UB schools. We have UB faculty from many schools that are actually all schools are part of the Community Health Equity Research Institute, and faculty from many schools, School of Public Health, School of Nursing, School of Architecture, were actively involved with this group called the African American Health Equity Task Force. But in 2019, the UB committed to a university-wide institute, the Community Health Equity Research Institute, and provided real dollars to support this community-wide institute, whose mission essentially is to do research to understand the root causes of health inequities, and then develop solutions to eliminate these inequities with a focus particularly in African Americans, but definitely also in other racial, ethnic, and under-resourced and underserved groups. Uh, and our vision is wellness and social well-being for everybody in Buffalo and everybody in Erie County, including those underserved who reside in underserved neighborhoods. So Let me also say that if we could solve, I think I told you that a black person dies 10 to 12 years younger than a white person in the city of Buffalo. And a black person has 300% more, a higher rate of chronic illnesses than a white person in the city of Buffalo. If we could solve all of the healthcare access problems and healthcare in the city of Buffalo, that would improve health outcomes by about 15 or 20%. The other 75, 80, or 85% come from what's called, and you likely know this, but maybe it's new to some people, the social determinants of health. That includes poverty, substandard housing, education opportunity, food insecurity, access to transportation, inequities in the criminal justice system, Wi-Fi access, walkability of neighborhoods, and so forth. It's all of these determinants that account for the tremendous health inequities that exist in our neighborhood. So if we're going to change health outcomes, we need to address all of those. And that's the concept here in the Community Health Equity Research Institute. So we have all 12 schools represented because I think many people think of health equity, they think, oh, it's only the health sciences, that's a health problem. But in fact, it's a problem for all of us at UB and all of our disciplines. If we're going to change inequities in the criminal justice system, we want the School of Law involved. If we're going to change substandard housing and crumbling neighborhoods, we need the School of Architecture and the urban planners. The Buffalo public schools are a struggling school system, and our kids who go to the Buffalo public schools, which is 80% underrepresented populations, are just not competitive, even when they graduate. Low graduation rate, and even those who graduated are not competitive. Many of them for the good schools. So we want to attract and engage and support faculty from many disciplines. And I think many of our faculty outside the health sciences are not as aware, perhaps, as they should be, of how their work interfaces with health equity. And so I want to finish in the last 5 minutes to tell you about a new opportunity, particularly for the early career faculty who are here. So we just received a grant from NIMHD, the Institute did, the Community Health Equity Research Institute did, the National Institute of Minority Health and Health Disparities, and it's a center of excellence in investigator development and community engagement. It is essentially a training grant. And this is the big part. It's a 3.6 million, it's a $450,000 a year. $300,000 of it goes to support community-based pilot projects for early career faculty and postdoctoral fellows. And so we will provide those, and we will help mentor and train new faculty in the area of health disparities and health equity research. So this is in the RFA. We have no choice but to every year, according to our notice of award, $300,000 have to go to pilot studies. And these awards will be big ones, between 50 and 100,000 per year for 1 year or 2 years. The idea being we want to jumpstart faculty to be able to go out and get the big grants and then establish their own independent programs in health disparities. So the goal of this whole grant, according to NIMHD and our goals, are to support new investigators to establish their own independent research programs. And so any career and early career faculty with appointments at UB are eligible, in addition to postdoctoral fellows. Both basic science fellows and clinical fellows are eligible. This is the NIH definition of an early career investigator. Essentially, it's 10 years out from your training. So someone who is in kind of a basic science would be following your PhD 10 years out from your PhD. Someone who's in a clinical specialty, an internist, for example, or an infectious disease person like me, you would be after your residency and fellowship, which are largely clinical training, 10 years out from your training, and then you cannot have an RO1. If you already have an RO1, you're no longer considered an early career investigator. You can have all kinds of other smaller grants, R21s and other grants. That's okay. You can't have an RO1. So, on the RFA, and I'll give you the link to the RFA, the request for application for these pilot studies, you can get the precise definition, and then sponsored projects can help you, or we can help you too, to figure out whether you still qualify as an early career investigator. So we have released the RFA. It's out there, and you can get the link down below there for the full RFA. We're going to have an informational session online on September 16th. That's on Monday at 10. We'll record it. So if you're not able to attend, you'll have it, and that'll be we'll give you the nuts and bolts. We'll walk through the RFA and answer any questions people have. And then it's a 2-page letter of intent that's due October 8th. And then we will we have a committee who will review both a scientific review and community review, and we will invite full proposals. So we don't want everyone writing a full proposal. If we get 25 people applying, and we can only give out, somewhere between 3 and 6 of these things. So we will invite people to submit full proposals, which will be essentially like an RO3 application to the NIH, a 6-page proposal. While you're writing your proposal, you will present to our community advisory board looking for advice. Full proposals will be due in November 22nd, and then funding would start February 1st. The 3 key requirements, the last slide here, are: 1, we want you to address root causes. We don't want Band-Aids or charity. We want to understand some of those root causes that I outlined, and there are more than what I outlined, of how we might be able to change those. We want to, you have to include a community partner. If you don't have one, we can help you find one when you're writing the pilot study, and they need to be lead to a larger extramural funding. We want you to write in your proposal your path to where this is going to larger funding. We're not going to eliminate root causes with $100,000 grants. That's where you can get the big grant, and to establish yourself as an investigator and to really do the big research to eliminate these root causes. I had 2 summary slides, but I will circulate the slides, and I will stop here to stick with the timing.
Thank you, Dr. Murphy. We do have one more poll before you guys leave for our break before lunch. So if you could answer those questions, that would be greatly appreciated. And then we will see you at 12 o'clock to look at sponsored projects and research funding.